Good morning, everybody. Welcome to this case study review of lifestyle management in MASLD and MASH. My name is Whitney Steinmetz. I'm a family nurse practitioner. I practice in Albuquerque, New Mexico through Presbyterian Medical Group, and really happy to have you here this morning. So this is going to be a case-based presentation around the lifestyle management. So we're really going to focus in on that aspect of patient care in this patient population. And I think a case-based strategies are a really excellent way to do that. I already introduced myself, but in case you want to see how to spell my last name, which is always a treat. So if you haven't already done it, for those who are logging in or are going to watch this later, make sure you use the QR code to register for the meeting so you get credit and can get CME. And then also make sure you go on the GAP website or download the GAP ACE app and see all the different modules that are on there for patient education and provider education, and review more information around MASLD and MASH. So let's get into the case study. So this is a 65-year-old male. This is Albert, and he's been referred to your clinic for elevated liver enzymes and abnormal imaging with an abdominal ultrasound that showed increased steatosis and concern for increased echogenicity. So the things you want to key in on here are the fact that he has some laboratory values here. And the big thing that caught my attention was that he's had an elevated ALT for the last 3 years. So we know that an ALT level is correlated with abdominal adiposity, especially visceral fat. And we often see elevated ALT levels in patients with central obesity, in MASLD and MASH, because it's a manifestation, or it creates a perfect situation for people to have insulin resistance, and is a way for us to key in on that they have other factors related to metabolic syndrome. So that's a really important component of this laboratory evaluation. Plus, it's always good to look at their platelet count. That can be a manifestation or certainly a clue that there might be something more advanced happening here in the liver. And when we talk about evaluation for other chronic liver diseases being negative, we're talking about a serologic workup here. So has he been ruled out for viral hepatitis? Has he had a basic autoimmune workup? Things like this. And in this situation, as a real miracle, he showed up to your clinic having that already done. So that's all been negative. So as far as the alcohol history, whenever patients say things like this, that they've had no alcohol in their 20s, I think that's a really good opportunity to talk about what exactly that means. Does that mean that in the past they might have had an unhealthy relationship with alcohol? Are they truly not drinking alcohol ever? Or are they just not drinking in ways that they used to? And the reason why I make a point of that is that we know that in patients with MASLD and MASH, that alcohol can have this accelerant type effect. So it's really important to get more information about an alcohol history and just start a conversation around that. So this medical history is a really common one we see in patients with MASLD and MASH. And to be honest, it's a common medical history for a lot of patients, and should really tip you off to this outside of you seeing a patient for elevated liver enzymes. Even if you're seeing someone for another reason in your GI clinic, seeing a medical history like this should really tip you off to perhaps some necessary screening. So on physical exam, really common that these patients don't have stigmata, but we often see abdominal adiposity, and I try to be really mindful about documenting that on physical exam, because it really paints a picture, I think, that's really important. So after we've done all this, we can very confidently and strongly say this patient has metabolic associated steatotic liver disease, and kind of move forward on what the next steps are. So this is going to kind of walk through the pathway here through the AGA. These are new, easy guidelines. I love guidelines like this that make it so simple just to follow exactly what needs to happen here. So the first thing we have is we already have lab work here, right? So all we need to do is take that lab work and plug it into a calculator. So his FIB4 is 2.22. And what are we going to do with that? So again, this is why these things are so great and make it so simple for everybody, including the people that we're collaborating with in the community, the endocrinologists, the cardiologists. even ourselves in clinic. So we've calculated the FIB-4, and the FIB-4 has told us that there's some indeterminate risk. Some of the reasons why this might have happened is because that we know that the FIB-4 score certainly isn't perfect. It's an excellent screening tool, but we know that in patients that are 65 and older, there's some limitations in the test. So there can be lower specificity, and we know there's some physiologic changes that happen with age, and aging can affect our liver stiffness. So that might have been the reason why in this particular patient, we had this kind of question mark come up after the FIB-4. So what do we do after that? So often the next step is to get more information. And that's often what we're doing in medicine, right? If we're not sure or something's unclear, more information is almost always the right step. So in this situation, we want to use another non-invasive test, or a NIT. So the choice here was to do a FibroScan, which is an excellent non-invasive test. MR elastography is also available more widely in some communities. I work in a more rural healthcare environment, so we actually just recently were able to obtain MR elastography, but it's something that's not being read by a lot of radiologists. So we try to reserve that for those extra difficult cases where you're really not sure. So FibroScan is an excellent tool. So the patient goes and gets a FibroScan, and his KPA is low risk. And again, the excellent part about this infographic is you don't even really need to memorize all these numbers. You just look, kind of plug in the numbers and see what you need to do. And we know that in this patient, that he's really low risk to have advanced fibrosis, and that we should repeat this non-invasive testing in 2 to 3 years unless there's some kind of clinical change. So that would mean, has he had uncontrolled diabetes for the last year? Has he had more weight gain? And would that maybe prompt you to repeat it in a year? Possibly. So what do we do in this situation? So what do we do in gastroenterology? So I think it'd be easy to just punt the patient back to primary care, but I think there's a real opportunity here to do better. And I think the ways that we can do better is to give a more focused recommendation about lifestyle modification, about how to optimize his other metabolic diseases, and give really clear recommendations to our colleagues in the community about what to do next. And I think we have the opportunity to do that here. So we know that MASLD is a continuum, right? And often, instead of the or at the top of the screen there, I'd really say it's and or, because a lot of these patients have and for all of these things. They have increased abdominal adiposity. They have type 2 diabetes. They also have hyperlipidemia. They might have other endocrine disorders or hormone dysregulation. And we know that that really creates a perfect storm for the development of clinically significant fibrosis. This infographic is something that I use all the time when I'm speaking to patients. I think infographics like this are a really powerful tool because it helps patients to see where they're at and what we're trying to prevent and where we have the opportunity to make change. So these are questions that patients are going to ask you all the time: is what stage am I in, and what does that mean, and do I have cirrhosis? And I think this is a really important tool, and it helps them to see where we can make changes and prevent this continuum from progressing to an advanced liver disease picture. So the risk factors and pathogenesis is really important here. And the thing that this slide really summarizes is that genetic variants, like the ones listed here, really impair triglyceride breakdown, VLDL secretion. They increase lipogenesis and oxidative stress. So that also plays a role in the foods that we're eating, including saturated fats, which we know promote inflammation and cause reactive oxygen species. Fructose increases lipogenesis and fatty acid oxidation, as well as just general oxidative stress. And dietary fats also influence inflammation. And these factors can all lead to steatosis, inflammation, MASH, and even progression into cirrhosis. So really important to think about that, but also remembering the genetics. And we're going to get into a little bit later about why that's important when we're talking about lifestyle modifications in our patient who's here to see us in the clinic today. So we know the obesity pandemic has caused a significant increase in type 2 diabetes, and thus seeing a lot more MASLD, it's always been there. It's just we're much more aware of it and seeing what can happen. And I think, rather than letting it be the elephant in the room, the really important thing here is just to address these things. It's well within our purview in gastroenterology to talk about these things and play a more direct role in managing them. And also just to be the drivers of change here, to not keep pushing people to more specialists, but to take ownership. We know that this is the root cause of the issue. So important to be talking about it in clinic and addressing these things directly. I don't think this is a primary care issue. I think it's an issue that affects all of us, and we all need to be talking about it with patients and working together to create a plan for them that makes sense and helps them to improve their lifestyle. So the balance is really important here. So we know that there's this balance of factors that are really important, and it's a balance between the nutrients and energy intake, and that central obesity is a really important part of that. And we're going to talk a little bit more of that on the later slides. So let's get back to our clinical case study. So we know that there's some opportunity for discussion here. Lifestyles are really, food is a really important part of that. So how do we talk to patients in a culturally considerate way? So Albert's explaining that he has a traditional Cuban diet, and how can we discuss that with him in ways that are culturally competent, but also gonna help impact change. So I think the best thing to do is to, ask patients what their usual meals are. Just tell me more about it, acknowledge the cultural part of it, acknowledge the socioeconomic parts of it, be realistic about what you're telling patients to do. A big thing that I see people doing a lot in clinic is kind of giving patients recommendations that would be hard really for anyone to follow. So, nobody's eating salad 3 days a meal, 3 days, 3 meals per day. We're not all only drinking water. So I think figuring out where are like the targeted ways that we can make a change here. So when we talk about how people are preparing their meals, one easy way is, rather than telling people not to eat the things that are an important part of their culture and their diet, is thinking about how can we prepare those things in ways that are healthier or more healthy for the liver. So oftentimes that involves using less lard, maybe using less salt, maybe trying to bake things rather than fry them, shifting to more leaner meats if you can, or if pork and beef is a really important part of their diet, I often try to encourage people just to increase the portions of the other things on the plate. So rather than having meat be the superstar there, having, larger portions of leafy greens or vegetables or the other things they're eating. And then the big thing is helping people to try to reduce really high fructose sodas and fruit juices. So, water or decaffeinated teas or just less sugar is a really important way. And also acknowledging that we want people to do this most of the time and not all the time. We all have to live in a world that makes sense and participate in the things that feel good to us with our families, and also try to create change. And the best way to do that is to be realistic and think about doing that in ways that are culturally competent as well. So I think motivational interviewing is a really important part too. If you're not already using motivational interviewing when you speak to patients in clinic, that can be a very powerful tool. So lifestyle modification, we know dietary changes and exercise have always been the mainstay of therapy. We have other medications available to us now, but really it always is in conjunction with lifestyle modification, which is really important. And I think we could all be better about the education that we're giving patients in the clinic. So we know that weight loss is directly improved to histologic outcomes, especially patients who are able to lose that 5 to 10% total body weight. And some of the really important ways we can do that is, in addition to meeting patients where they are, trying to kind of target our recommendations. Like if sodas are a big part, how do we get that down? But also the big thing is caloric restriction. A big thing I see patients doing a lot is they are actually making, fairly really reasonable and really important lifestyle changes, but they're not reducing their calories. So that's a really important thing, is talking to them more about how do we get caloric reduction. So the efficacy in diet and exercise may be impacted by genetic polymorphism. So what does that mean? So remembering back to that slide, the pathogenesis slide, when we talked about the genetics that are in play here, we know that those genetic polymorphisms affect the way we store fat in the body, the way we process nutrients, the way we respond to insulin, and how we regulate inflammation. Like for example, on that slide, like the PNPLA3 gene, we know that's associated with having higher liver fat content, greater progression to MASH, and a reduced response to standard lifestyle interventions. And so I think it's important to know that because although it's really important to talk about these lifestyle factors, it's not the only thing that's going on here. There's definitely people who have a genetic predisposition to this, and we all can probably think of that patient in clinic who we're all kind of surprised because they don't kind of meet the criteria that we're used to, or they're doing the things that we're asking them to do and we're not seeing the changes that we expect. And so important to keep that in mind when you're talking to patients and also when you're following them up and kind of scratching your head about what else could be going on here. So speaking about exercise, which in addition to diet is a really important part of this. So we know high intensity interval training is not as effective as other forms of exercise, but the big thing that I want everyone to take away from this slide is that you just want to try to get patients moving. I'm not sure, I would go if a patient's doing a lot of high intensity exercise or interval training, I wouldn't go out of my way to discourage them to do that. I think the point here is that this idea that if you're doing nothing but HIIT exercise or high intensity interval training, that's going to solve everything. The big thing is you want moderate intensity aerobic exercise targeting, greater than 150 minutes a week, and really consistency is key. So what are patients doing and how could we do more of that? So are we walking to go get the mail? Could we maybe make some extra trips rather than getting the mail on the first jaunt? Maybe we can do 10 laps before we do that. If they're already walking in the neighborhood, are they walking until they're out of breath, or are they able to have a conversation when they're doing that? So maybe we can make those modifications that way. A lot of patients have told me they will park their car farther away from when they're doing their errands. Or I've had parents who say they'll actually use more carriers for their kids, almost like a weighted vest to help them to optimize the exercise they're already doing when they're at the park with their kids, trying to stand up more, walk around more, be more engaged in ways that you can try to, what are they already doing and how can we optimize it? That's always what I'm really trying to get at here. So, again, caloric restriction is a really important part of this. I think sometimes we get too down in the weeds about the food and all those things, and it's really important. But again, if they're not reducing calories, they're probably not going to get as much of the changes that we're asking, and that can be a frustrating process for everyone involved. So again, we know there's that genetic predisposition, so everyone's response to a specific diet is not always totally understood and certainly, but also plays a factor. So a Mediterranean diet is the one that's most supported as the primary lifestyle intervention. It's probably one that patients really understand the most. So we want to try to take a more personalized approach at the same time. Thinking back to our case study, Albert, is a Mediterranean diet. How can we take the components of the Mediterranean diet to what he's already doing? How can we make that work? The other thing I would tell you here that I see happening a lot is, be really mindful about the fact that a lot of this patient population is getting a lot of mixed messaging around diet. So a lot of them have other specialists, right? So sometimes they have a cardiologist, they have an endocrinologist, they have a nephrologist potentially, and they're a lot of times getting a lot of really confusing information for them. So they're being told that their cardiologist like a DASH diet, they're being told by their nephrologist protein restriction, then they come to GI and we say you need more protein and Mediterranean diet. And so I think it's helpful to figure out what they've been told and try to figure out how do we meet the needs of everybody, and how do we decide what's important, keeping in mind that the human on the other side might be getting a lot of conflicting information. And this can be a really nice opportunity for a nutritionist. But again, not everybody has access to that. And also even going to the nutritionist can be confusing because if they're being sent to the nutritionist from cardiology, it might be a different message than when we send them from gastroenterology and et cetera. So keep that in mind when we're talking to patients that, a lot of times it can be confusing. So let's go back to our clinical case study here. So we remembering Albert. So he returns for some follow-up. He hasn't had any improvement in his labs. He's been exercising, or he's not been exercising. He's not begun any exercise regimen, but he's been trying to cut out soda. So how do we work with patients to create behavior change? First, I think I would applaud that he's been trying to cut out soda. I think that's a really powerful thing to do. We talk about like what are those really important interventions that we do. High fructose sodas are a really important component of that. So I would applaud that. And then figuring out what the barrier is to exercise. For a lot of patients, they have pain. It might be really difficult for them because of, depending on how much excess weight they're dealing with, it might be really difficult to even be able to walk. So figuring out like where the barriers are and how do we help. One of the things that has been helpful for me when I'm trying to get patients to create behavioral changes is not telling them the same thing every single visit. I think, if the thing that you said didn't cause or promote a change, it's not that you did anything wrong. It's just that there was something about that message that maybe could have been different or didn't relate to that patient or wasn't something that felt applicable to them. So I don't keep doing the same thing every visit. I think when we do that, we're not conveying a seriousness. I think when you change it up and try something new, you're conveying kind of the seriousness of it. And so, for example, this is an opportunity to, do we send this patient to bariatrics just to have a conversation? Do we try sending them to a nutritionist? Do we ask them to bring a family member with them to the appointment? Do we like get a family member on the phone in the visit and talk about, what can we do? Can we all try to support this patient together? Are there other people in the family that have health issues that we can all work together? That's when I just start bringing in all these other different types of tool, and I try to do something different every time. And often that can be a really, really effective strategy. So, a lot of us are utilizing screening questionnaires in our clinic. A lot of our medical assistants and staff are so pivotal in helping us make this happen. A lot of times, a lot of clinics are already set up because it's part of a quality measure to screen people for depression, screen people for alcohol use. This might be another tool that you can bring into your clinic that allows people to kind of see where they're at and see how they're doing, assess their response. I don't think these things are helpful for every single person, but some patients really want to see a progression. They want to see a change. Again, thinking about that strategy of the patient who you didn't get the type of change response that you were expecting. Sometimes a tool like this can be helpful for them to track their own changes and to see how they're doing. And this can be helpful. It has a lot of criteria to monitor for. And again, know your patient, know what they're going to be capable of doing, but this can be a really important tool. So that's it for this part of it. If anyone has any questions, feel free to contact me. I know my information is available on GAP, and there's so many other resources there. And thank you so much for your time. I hope you enjoyed it and learned something.